Bismillahirrahmanirrahim. Post-menopausal bleeding, which is the most common presentation for the malignancies of the uterus, so especially the endometrial carcinoma. So this is approach to the post-menopausal bleeding. Let's see the endometrial hyperplasia and the endometrial carcinoma. Okay, and endometrial hyperplasia means the overgrowth of the endometrium. Okay, so you know better in the reproductive age, when during the menstrual cycle. So the endometrium is continuously grow under the action of estrogen and the progesterone. So estrogen, which is and progesterone, which is coming from ovary. So in the first phase, which dominated the estrogen. In the second phase, the progesterone dominate. Okay, so then they both withdrawal, so that can lead to the normal menstruation. So if in the postmenopausal there is no ovulation, so if the estrogen comes, so it continuously grow the endometrium, which can lead to their hyperplasia, and which in the advanced age that lead to the malignancy. Okay, so if you look at the normal thickness of the endometrium before the menopause, so during the menses, so you see a 2 to 4 millimeter, 5 to 7 in the proliferative phase. In the late proliferative phase, you will see the 5 to 7, and it reaches up to 16 in the late stage, and in the secretory stage, it's a 7 to 16. But in the postmenopausal, it should be less than 5 millimeter. If it's greater than 5, you should think of the malignancy, okay, or the endometrial hyperplasia, because it's a pre-malignant condition. So why this happen? Because if there is no ovulation, or due to increase estrogen without progesterone, so and the endometrium continuously grow, and eventually it will rupture, so that lead to the bleeding. Okay, but anovulation is same thing, mean there is no over release. So because no over release, no corpus luteum, no progesterone, so no progesterone lead to the irregular bleeding. Okay, if you compare the hormonal level before menopause and the after menopause, what is happening? So normally, because before menopause there is a normal cycle of the menstruation, so both progesterone is high, and but after the menopause the progesterone level go down, and the estrogen, so it's somehow remain high, because due to obesity, or if someone is taking the hormonal replacement therapy, especially the estrogen only, so that can cause the endometrial hyperplasia. Okay, so this endometrial hyperplasia can bleed. So how they clinically present? So there is pain, or with discharge, abnormal uterine bleeding, or you can say the postmenopausal bleeding. And this is the presentation due to endometrial hyperplasia. Okay, so that rupture and cause the bleeding. Okay, so why this hyperplasia? You know better, due to increased estrogen without progesterone. Okay, and the endometrial hyperplasia is a pre-malignant condition, so the increased risk of malignancy. So this is the normal endometrium. So here is the hyperplastic endometrium, and this is the malignancy, endometrial carcinoma. Okay, there are different type of the hyperplasia. It's a simple, or with atypia, complex, without atypia, with atypia. So these are the risk for the endometrial carcinoma. So if you look at here, this is a without atypia. So although it's a endometrial hyperplasia, so in the without atypia, you see the increase in the gland, and also the increase in stroma level. Okay, so but and the gland are the different shape, so they are irregular type. Okay, if without atypia, you see that there is stroma is decreased, and the nuclei has been atypia, mean their structure is abnormal of the nucleus. So this is with atypia, so which is the which has greater risk for the malignancy. Okay, so here you can see the all the structure has gone, so dysplasia, and all the nuclei and the structure and the glands are destroyed. Okay, what is management step? So if the condition is the without atypia, give progestin. Okay, if with atypia, we give progestin. So if we want to conceive, otherwise we can do the hysterectomy. Okay, in the endometrial carcinoma, of course, we have to remove the uterus, also the fallopian tube, the ovary, so total abdominal hysterectomy, the plus the bilateral salpingo-oophorectomy. So and also remove the lymph node because there is spread in the lymph node. So we have to remove the pelvic lymph node. Okay. So there are different stages of the hyperplasia. You can see the first initially it's a cystic hyperplasia, meaning dilated glands, which is common in the menopause and or in the ovulatory teenager, which is not ovulating. Okay, and it's become adenomatous hyperplasia, so which is the without atypia, where irregular and complex glands you will see. In the atypia, you will see the nuclear atypia and abnormal the meiotic figures. Okay, so then it's become the endometrial carcinoma. Okay, so what is risk for the cystic hyperplasia? Up to 1.1% for the developing endometrial carcinoma. For this is the 3.4, and for the atypical, so it's 25 to 50 percent risk for the endometrial carcinoma development. Okay, so in the endometrial carcinoma develop in the glands as well as in the stroma. There are two types of the endometrial carcinoma. So type 1, which is most common, the endometrial carcinoma in the female genital tract, and in the overall it's a fifth most common tumor in the woman. Okay, and if you look at in the type 1 and type 2, type 1 is 90% it's endometrial and estrogen dependent, and receptor for estrogen and progesterone are positive, so that's why their prognosis is the good, and it's due to endometrial hyperplasia. And type 2, which is a high grade, and it has a poor prognosis, so it could be a serous or clear cell tumor or adenosquamous carcinoma, so it's due to atrophic endometrium. Okay, so it's a more the worst condition. It's a poor prognosis, but it's less common as compared to endometrial. Okay, type 1 is most common and type 2 is less common. So, but in the type 2 is the serous is the most common. Okay, and if you look at the mutation, P53 mutation is common in type 2, while P10 mutation is common in the type 1. Okay, and they are both are associated with the Lynch syndrome, which is what the hereditary non-polyposis colorectal carcinoma, so where you see the multiple polyps, and they are also associated with the endometrial carcinoma and ovarian cancer. Okay, so that is the Lynch syndrome. Okay, so these are the mostly carrier of the Lynch. So here you can see the endometrial type, where you see back to back the glands are present. Okay, so here is you see the clear cell, which is type 2, and you see that you can identify the nuclei. So here you can see the clear cell and the papillary serous, which is a serous type, and it's a papilla, okay, finger-like projection. So while this is the clear cut margin, and you see the nuclei. Okay. What are routes of spread? So there is number one is the direct way, mean directly enter into the myometrium. So it's a myometrial invasion. So direct. The other is the lymphatic and the blood. Here you can see the direct invasion into the myometrium, and it can spread into peritoneum. And if you look at lymphatic, so they are involving the external, internal iliac lymph nodes, the obturator nodes, inguinal node, para-aortic node. So that's why whenever we do the surgery, we remove all these lymph nodes also. Okay. What are investigation we can do? Hysteroscopy to look at the close view of the endometrium and take the endometrial biopsy, and ultrasound, and CA1 to 5 because its level increase during the endometrial tumor or the ovarian tumor. Okay, so this is suggested for the tumor condition. How we approach the endometrial carcinoma? So start with the transvaginal ultrasound. Okay, so transvaginal ultrasound, where you want to see what endometrial thickness. So if the endometrial thickness is more than 5 or less than 5 millimeter. Okay, so if it's more than 5, so and you see the risk. If the low risk, then you do the office endometrium biopsy or SIS, means saline infused sonography. Okay, if the risk is high, then you can go for the dilatation and curettage biopsy or via the hysteroscope. Here you can see the office endometrial biopsy. Okay, so which we usually do in the outpatient or low risk patient, and this is a saline infused ultrasonography. It's important because sometimes the small polyps which cannot be visualized by ultrasound normally, we infuse the saline which gives the better picture. So here you can identify the polyps. If the risk is high, mean inpatient or a hospitalized patient, so then you go for the dilatation and curettage, which is the gold standard for the diagnosis, or you can do the hysteroscopy. Okay, so if the endometrial thickness is less than 5 millimeter, you should do the follow-up. Okay, if the after the follow-up, you mean you give the some initial dosage and the symptom improves, so that's good. If the bleeding persists, then you of course do the biopsy. Okay, biopsy via the stethoscope. So this is approach toward the endometrial carcinoma. So basically, when you look at the uterus, so there are actually two types of a tumor. One is associated with the endometrium, other is associated with the myometrium. So tumor of uterus are the most common are the endometrial tumor, which is 7 to 80%. Other are the sarcoma. So small discussion for the sarcoma. Just remember, it's a rare because only 1% of genital tract tumors, and it's a rare mesodermal tumor. Okay, and but it's a highly malignant tumor, so it's dangerous. So there are different histological types. Mostly it's due to the untreated the fibroid, which is leiomyosarcoma. The other types are the endometrial stromal sarcoma or Mullerian mixed tumor or sarcoma botrytis. Okay. Okay, what is treatment? Treatment is surgery plus radiotherapy. Surgery means you have to remove the uterus, total abdominal hysterectomy, bilateral salpingophorectomy, and you have to remove the lymph nodes. So this was small discussion of sarcoma. Let's see the stages of the endometrial carcinoma. Okay, so this is the endometrial. So FIGO is giving the stages for the endometrial carcinoma. So stage 1, 2, 3, 4. Okay, stage 1 is limited to the uterus, mean it's involve the endometrium and the myometrium. So if it's limited to the endometrium, it's 1A. If it's invade the myometrium but less than 0.5, so it's a 1B, and if more than 5 millimeters, so it's a 1C. So but the stage 2, it's involve the cervix also. Mean the tumor expand from endometrium and reaches also involve the cervix. So this is cervical involvement. Okay, so 2A and 2B. 2A only involve the glandular, while 2B involve the stroma as well. Okay, and then you come to 3, which involve the other structure, mean adenoxa, mean all the other structure associated with mean the fallopian tube, ovary, so all other structure of the female genital tract, so they are involved in the pelvis, mean. So they involve the serosa, adenoxa, the peritoneal. So this is the 3A. Okay, if it's reaches to vagina, so it's a 3B. When involve the pelvic lymph nodes or the para-aortic lymph nodes, so this is 3C. Stage 4, which is outside the pelvis. Okay, so mean it's the most common site for the spread of the especially the distal metastasis is the lung, liver, brain, bone, lung bones. Okay, so and the tumor 4A, which involve the bladder or the bowel, and the B is when involve the lung, liver, bone, and other structure. Okay, distal metastasis. So, and the prognosis of the endometrial carcinoma depend on the how much myometrial invasion is occurred and the differentiation degree. So, how much differentiated cell is present. So, grade 1, when the undifferentiated cell is less than 5%. If it's 5 to 50, it's a grade 2. If it's the undifferentiated cell are more than 50%, it's a grade 3. Okay, and we need to look at the palliative and tumor size and the age. So these all factors define the prognosis of the endometrial carcinoma. Okay, so grade 1, grade 2, and grade 3. Let's see the summary of the endometrial carcinoma. Okay, so tumor arising from endometrial gland, and it's the most common presentation is postmenopausal bleeding. You have to take the postmenopausal history and the white race and the nulli gravida or the PCOR. She is taken the tamoxifen. So these are the commonly associated history with endometrial carcinoma. Okay, in the differential diagnosis, you have to look at the other causes of post-menopausal bleeding. Okay, what are the sign for the endometrial carcinoma? If there is metastasis, you will see the fatigue and lower body weight, muscle wastage. So you will see the if there is metastasis, you will see the anemia, jaundice, the liver is involved, and the varicose lymph nodes, lymphadenopathy. Okay, so and if you look at the abdomen, you should palpate the abdomen. You will see the enlarged soft uterus plus or minus the sign of the metastasis. You may see the palpate the liver. Okay, and there is ascites due to metastasis. And if you go for the pervaginal examination or bimanual examination, you will see the enlarged soft uterus. Enlarged soft uterus. Okay, plus or minus, you will see the adnexal mass if it's metastasized. Otherwise, at least you see the enlarged soft uterus. Here is the cervical examination of the cervix. You have to rule out the cervical abnormalities. Okay, what are the risk factor? In the predisposing factor, the major is the estrogen due to many causes: menarche, PCO, the late menopause, granulosa cell tumor, or the estrogen replacement therapy, obesity, tamoxifen, and in the pre-malignant, of course, the endometrial hyperplasia. What are the finding in the endometrial carcinoma? If you in the local, it's look like the polyp. Okay, you go for the biopsy to confirm your diagnosis, and the thickness should be more than the 5 millimeter of endometrium. Okay, in the histological types, we have already discussed these different types and the grades of the endometrial carcinoma and the spread of the endometrial carcinoma. What investigation we do? Initially, we start with the ultrasound if the thickness is more than 5 millimeter. Otherwise, we can do the hysteroscope. Okay, and we do the DNC dilatation and curettage, and do the endometrial biopsy, which is gold standard, to confirm your diagnosis. Okay, and look for the chest X-ray, abdominal and pelvic ultrasound, and bone scan to why to check out the spread of the endometrial carcinoma. Okay, so metastasis, and also for the myometrial invasion or for the lymph node involvement, you have to do the MRI, because MRI is for the soft tissues. ECG, and we have to look at the labs, because we want to assess the patient fit for the surgery. Okay, because the management in the endometrial carcinoma is only the surgery. Okay, and plus or minus radiotherapy. In the stage 1, where the carcinoma is limited to the uterus. Okay, so we have to do the surgery. You have to, and also follow the radiotherapy. Okay, in the stage 2, we do the radical hysterectomy. Okay, and why? Because in the stage 2, it's also involved the cervix. So we remove some extra tissue also with the uterus. Okay, and we remove all the lymph nodes and follow the radiotherapy. In the stage 3, where the condition is more worsened, it's separate to the hole in the pelvis. Okay, so we do the radiotherapy, external beam for the pelvis, or extended where you target the pelvis and abdomen. Okay, in this stage 4, it's a measurable condition when you have to just improve the patient condition, quality of life. So it's a palliative, you have to relieve their pain and give the radiotherapy to improve his standard of life. So this is summary of the endometrial carcinoma. Okay, so this is a total hysterectomy where you only remove the uterus. In the radical hysterectomy, you also remove the nearby tissue, and this is removal of the uterus plus the fallopian tube and the ovaries, salpingo-oophorectomy. So thank you very much. Allah Hafiz.